Really exciting presentation today. As you can tell, Rachel and I have worked together before. But Rachele Hendricks-Sturrup is the research director of real world evidence at the Duke Margolis Institute for Health Policy and the former data governance officer at the National Alliance Against Disparities in Patient Health. She recently joined the Academy Health Advancing Research on Trust Initiative as a scholar in residence. She does research and practice expertise as a health scientist, engagement expert, and bioethicist, and by the way, fantastic speaker and writer. And her focus is on examining and addressing ethical, legal, and social implication issues at the forefront of policy and health innovation. Her talk today is entitled Policy and Ethics and Innovation, Developing and Applying Ethics and Equity Principles, Terms and Engagement Tools in AI and Machine Learning. And I think the plan is that you're going to talk for about 20 minutes, and then we are going to open it, and then you're going to open it up for informal questions, and I am going to watch the chat. Actually, what I prefer people to do is raise their hand if they can, but I also will watch the chat just to make sure that we give everybody a chance to talk. So with that in mind, I am turning it over to you, Rachel.
Awesome. Thank you for the very warm introduction. I'm glad to be introduced so in such high regard by someone as awesome as you, Ellen. So this is really exciting for me, and also exciting because I participated in a Bridge to AI meeting before where many folks said, tell us what you're doing within Aim Ahead, within the Ethics and Equity Work Group specifically, because we want to learn from you and understand your processes, your engagement methods, and what it is that you all are thinking of developing to deliver to communities like us that are looking for guidance. So before I get started, I want to confirm, because I have two screens open, but I want to confirm that everyone can see my slides in full screen mode. Okay.
They're
awesome.
not in full
Nope.
screen mode. They're in your you're not in presenter mode yet. You're in where we can see all the slides.
It's showing as presenter mode on one of my screens, so I'll have to change it to that one. So it should work now.
There it is.
Okay.
Yep.
Okay. All right. That's the joys of having the ups and downs of having two screens. Okay, great. So thank you again for introducing me. As Ellen mentioned, I'm the research director of real world evidence at the Duke Margolis Institute for Health Policy. We're based in Washington, D.C., and also based at our main Duke University campus in Durham in North Carolina. The work that I'm presenting today is work that I did under my former role as the Chief Data Governance Officer at the National Alliance Against Disparities in Patient Health. So for the past few years in that role, I had the privilege of engaging with Ellen and Brad and lots of others as part of the Aim Ahead consortium, which is, as you'll learn, it is a consortium that is sort of like Bridge to AI, focused on enhancing diverse perspectives in the process of building AI and machine learning tools and technologies to support health research. So with that in mind, I want to start with sharing with you all our publication in Jammer AI, or JMIR AI. I'm not sure how most people refer to it. Some say Jammer, some say JMIR. But anyhow, we published our work recently in December of last year on developing ethics and equity principles, terms, and engagement tools. I'm listed as the first author of this publication with several others that you see listed here, including folks in the room with us today. In April, there were just around 275 views of our publication. So we're happy to have had many eyes on this, and I'll talk more about the impact that it's made since then a bit later on, so you could see the full scope of of our, not just our viewership, but also our impact in broader policy conversations. But that being said, feel free to have a look at the full paper. This is the title. This is where you can find it in the journal. I do have a QR code that I'll share in my later slides. But just to tell you all our story, as part of this working group effort within the Aim Ahead Consortium, we came up with this background and rationale around the need for our work and deliverables that we felt were important to continue to move our work forward. So we recognize that AI machine learning is unfortunately not yet engineered to address all of our socio-humanitarian issues and complexities. And that's especially true for socially and economically marginalized communities. They themselves are frequently unheard, have limited engagement opportunities in research. I'm sure many of you know by now, or if you don't, you should know that individuals from socially and economically marginalized communities are represented in research writ large. That's clinical research, especially that evaluates the clinical efficacy of drugs that can be potentially life-saving, including other types of products like medical devices as well. And on top of that, if things go wrong in the process of delivering care to those communities, due to the use or potential misuse of AI machine learning tools, it's very rarely that these communities have the resources needed to speak up to the right people in power, so that justice can be served in those particular instances. And so I won't read all of my points verbatim, but I just wanted to highlight this and really drive it home as far as our background and rationale, that there's an overall lack of understanding about how AI machine learning works, awareness around bias issues for historically and presently marginalized populations altogether lead to mistrust or no trust in our health system, and that's a problem, and even our health research enterprise as well. So to build trust among those who are most subject to this sort of bias or risk, especially in health research settings, it's critical for AI machine learning developers to assess their own reliability, and I would argue trustworthiness, by first evaluating, therefore adapting their practices to build trustworthiness with our most vulnerable stakeholders in the clinical community. So the purpose of this work group, as it was created in 2021, within the Aim Ahead Consortium, was to guide the development and implementation of AI and machine learning tools and processes broadly within the consortium and hopefully elsewhere. As we got started, we were a work group that was situated within a very specific core within Aim Ahead, that is the infrastructure core. We quickly learned that the entire consortium could take advantage of this sort of coordinated effort and collaboration. So we quickly expanded to expand our activities across the entire consortium. And the goal and purpose of our work was to ensure that ethics and fairness are at the forefront of AI machine learning applications, such that we can embed or build equity into the biomedical research world. And that includes biomedical research education and healthcare that we hope ultimately benefits from this type of research. So with that purpose in mind, we started off in year one with around 50 members. In year two, that shrunk to around 40 members, all representing a variety of academic discipline and focus areas that you see here. I will say our membership shrunk in year two, mainly because there was some restructuring going on within the consortium, such that we had personnel move from one role to another. So it wasn't necessarily the case that people were less interested. It was more about, we just needed to restructure our work to be more efficient. Now, the one thing I'm very proud about is, like I mentioned, the variety of academic disciplines or people from the variety of academic disciplines that you see here. We had folks engaged with us from fields including medicine, but not limited to medicine, computational sciences, data science, bioethics, law, community engagement, human-centered design, and so forth. And this is I want to highlight that this is extremely important for this type of work as we endeavor to build out an ethics and fairness sort of list of principles and framework. You can't do this, can't happen with one discipline in mind or with folks from just one discipline in the room. That's really the major problem of today, where we have developers, AI machine learning developers in that particular sector alone, AI machine learning engineering, building out these things without all of these other very important disciplines in mind, especially as they move forward into implementation of the tools in various settings that are consequential, like healthcare and health research. So again, we're really proud to have had lots of different diverse perspectives in this work group engagement. So altogether, as we collaborated to develop a set of ethics and equity principles, that was our goal that we agreed on to develop that. Each member contributed their original thought leadership. We did that in a very systematic way. We reacted to relevant literature that's been published online. And we, from there, came up with a set of actionable principles. So in the process of doing that, this is what our engagement looked like, what you see on this slide. During year one, we held weekly meetings. During year two, that moved to bi-weekly meetings as we gained quite a bit of traction during year one. During these meetings, the group came together to suggest either verbally or through the chat or offline via email even, suggests literature that we should review. We deliberated together an extensive corpus of published content and documents that we all agreed could be useful toward integrating ethics and equity into AI machine learning development. The weekly meetings and subsequent bi-weekly meetings allowed us to gain and act on our consensus around the development of our work group deliverables, identify, as I mentioned, literature for inclusion, lessons learned from that literature that could inform the development of our goals to address the use of AI machine learning in health disparity and disease prevention research. We used as we narrowed things down to a certain set of principles and definitional terms that we wanted to clarify for the field. We used a modified Delphi approach to facilitate those discussions and reach those goals. And so with that being said, we were able to articulate and define and really flesh out 5 core principles. The QR code that you see here on the screen is what you can scan yourselves if you're able to review the full paper if you haven't already. But here are 5 core principles, each with its own subparts that are, again, fleshed out in the full article, highlighting or articulating best practices for working with community stakeholders, specifically those who are from historically or presently underrepresented communities, best practices that you could implement as you work with them. So here are the broad domains. Build trust with communities. Second, design and implement AI machine learning with intention. Third, co-create, do not dictate. A lot of times this is a problem in the scope and practice of AI machine learning development and implementation. Really, it's a top-down approach, and really it should be a bottom-up. Build capacity, especially for communities that don't have the capacity to engage in AI machine learning development and or adjudicate around its use and implementation in certain settings. And then lastly, reset the rules. Again, address some of the power structures and dynamics that are part of the system, or really that run the system of implementing these tools without the right governance and stakeholder buy-in controls in place. So that was the principles development. Next, I'll move to our process for developing the glossary. So together we explored and defined ways in which AI machine learning outputs can fail to be informative or useful for individual groups, to be poorly vetted by them, or any individual group of individuals really who could be subject to potentially harmful actions or decisions made by authoritative stakeholders that rely on AI machine learning for decision support, and also distinguished ways in which AI machine learning use or implementation might be inappropriate due to bias or failure to include specific groups that are affected by the tool's implementation, misuse around the tool as well. Again, we used a modified Delphi approach that involves polling, ranking, and other online exercises to reach consensus on a set of defined Sentinel terms. We identified 12 terms total that we felt would be useful to define for the sake of informing the ethical and equitable development and application of AI machine learning. And these are the terms that we came up with, those that are in the color codes that you see here. So there's algorithmic bias, bias as a function of that, inclusive, fairness and equity being functional within that term. You'll see equity is at the center of this entire diagram, where ultimately we want all of this to lead to or cultivate a culture of equity within AI machine learning development. We looked at representative sample, that itself being a function of representativeness in general, and that being a function of diversity, again, feeding into equity. And there are some examples of what diversity and representativeness looks like across certain demographic characteristics that we also felt were important to define. So that is ethnicity, race, gender, sexual orientation. Lastly, realizing that these tools would require further iteration as time goes on, or further discussion presently among implementing stakeholders that want to or would seek to take those principles and glossaries and implement them or adapt them locally. We thought it also good to develop an interview guide to support our locally implementing stakeholders in that regard. So initially we thought that a quantitative survey would be helpful for local stakeholders to do that. But upon further discussion and deliberation based on feedback from our aim-ahead stakeholders over the course of several months, we determined that a qualitative interview guide versus a quantitative survey would be more useful to accomplish that goal. And so we developed an interview guide, again, with the intent of learning from, or at least to support individuals, including ourselves, as they endeavor to learn interviewees' perspectives and natural reactions to the ethics and equity principles and the glossary. So really, the interview guide is meant to serve as an engagement tool where individuals like yourselves can sit down with folks and say, hey, take a look at these principles, look at this glossary. What does this mean to you? As we think about implementing them, even within our own organization, how ready are we to do that? So here's a glimpse of what those questions are here. So, for example, within this interview agenda, there are questions that say things like, hey, can you describe to us which principle resonates with you the most? Which principle applies to the work that you do the most? Some other questions can be a bit more quantitative, like on a scale of 1 to 5, how valuable are these principles and as they would pertain to your work or involvement with an aim ahead? These are the types of questions that our interview guide asks, and that can be adapted and implemented locally to serve your needs, particularly, or at least especially within the Bridge to AI program. Some limitations to our work are essentially what I just described. These are living documents. Because of that, they complicate the process of achieving sustainable consensus, but we're hoping that this can also be a strength for some that are just looking for somewhere to start as far as local implementation of these principles in the glossary. The interview guide serves as a tool to do that. We ourselves continuously revisited the principles and glossary for potential editing. Some of the proposed glossary terms themselves may already be limited in scope with respect to real-world events and phenomena. One example that the group pointed out, our definition of representative concerns an individual or body chosen or appointed to act or speak for an individual population or subpopulation. However, there are certain matters that should that we should keep in mind where a representative might be self-appointed without specific authorization among those or from those they are seeking to represent. So here's some, I have just a couple more slides left about our the impact of our work thus far. As many of you likely know, the president issued an executive order in October of last year, acknowledging that AI should reflect the principles of the people who built it or people who use it and the data upon which it's built. In 2019, in December, we found that the NIH Advisory Committee to the director, their working group on AI published a recommendation that NIH charge a new or existing working group to develop a set of ethical principles for the use of machine learning in biomedicine. We feel that we've effectively accomplished this goal on our own, or as a complement to this work group's charge or recommendation. I'm also happy to say that our work has helped make progress toward work set out by both the White House and the NIH ACD working group, mainly because I recently participated in an interview with the Department of Health and Human Services Task Force on AI regulation in healthcare, sharing with them these principles and describing to them how our work really fits into this broader picture of trying to establish working tools that and principles and glossary terms that could be useful for the entire nation, really, as we do this work together. Our work has been cited to date in a couple of papers that I saw. One of them is in preprint. These are two very, very recent articles, which is to be expected since our work was just published in December. But these are a couple of paragraphs, screenshots of paragraphs taken from these papers where they really dedicated an entire paragraph to talk about our work with an aim ahead, citing this paper. One of the articles discussed simulated misuse of large language models and clinical credit systems. We're also seeing practicing experts in otolaryngology as they expound upon artificial intelligence implications in this particular clinical setting. And so we're sharing this with you all to say that people are talking about this work and they're really looking to it for guidance and looking at us as a really high profile example of how this work can and should be done. So here's my email if you have any questions. I'm happy to talk with you all today for the remainder of this discussion, but also talk with you offline via email or at other venues if you'd be interested. Thanks again for inviting me, and I hope this was informative for your work.
Well, thank you so much, Rachel. And I have to say that you underplayed what a major role you played in the development of these guidelines. And so I want to open it up for questions or comments from those who are in the audience today. But I will open it up and ask you to say a bit more about how you can really do this kind of engagement and really feel like what you're getting is authentic and is going to be a major part of how we move forward, because frankly, there are a lot of concerns in this area.
Yeah, well, first off, thank you, Ellen, that your words are always so kind, and but I cannot understate how much, or at least how important it is to do this work together. It's one thing to have led it, but it's another thing to have actual followers as you lead this work. Sadly, we see a lot of people getting behind the message around ethics and equity in AI machine learning, but not many getting behind the practice of it. It's a very different thing. And this is where people and things start to fall apart. And so I can't emphasize enough how important it is to make sure that as you lead this type of work, that you are contributing to the broader vision so that those who are practicing around this or who want to practice around this, they know where to start with step 1, step 2, step 3. And what I've learned is that, people struggle to do that the most. So the whole, again, intent and purpose behind this work was to give people a sort of step-by-step framework to be able to do this. But I'll stop and let others talk. And I just wanted to close with that.
So I just put in the chat, people who want to talk, please raise your hand, or if you want to, you can put questions in the chat. That would be helpful. And Susanna's raised her hand, so there you go, Susanna.
Hey, Rachel, I'm not sure if we've ever connected, but I'm a big fan. So this is really great to see you present. And one of the things I've been thinking about is your use of the living document. And, because, I've been thinking about sort of atypical ways to engage stakeholders that actually mean something. Like, especially sort of in real time efforts of as we're developing models or pulling data sets together or whatever the question is, right? And one of the things I've been thinking about is like working asynchronously with documents and, especially with stakeholders who may have a diverse set of perspectives, literacy, disparities, educational background. And can you tell me a little bit more about your use of the living document and also, the pros and cons of this and maybe a way to expand it if you think that is actually a good way to do it?
Yeah, no, that's an excellent question. As I mentioned, even within our own group, after we all agreed that the principles are final, we're not making any more edits to them, we have to publish. We have to go through the publication process, which is long, depending on what journal you're working with. We had to struggle to rein people in several times to say, hey guys, we said don't go in. We use Google Docs, so it's a shared document. So that probably
it literally
answers one
is
of your
living.
questions. Yeah, it's truly living. And so unless you lock, the editing capabilities. So technically speaking, I mean, there are ways to overcome the livingness of a document such that if you're sharing a document with a group, you can allow people to only make comments versus allow people to make direct edits to the document. That's something that we had to do even within our group. It's something that others can do as they take the principles and the glossary and other tools and iterate on them themselves. But again, I think realizing that you have to stop at some point and implement somewhere. And it can be done technically through what I just described, and it can also be done by versioning techniques. So for example, like this document here is intended to be version 1.0. It's totally fair for someone to take this and create a version 1.1 or version 0, for themselves. It all depends on where people are at in their journeys locally, or at least as far as local implementation goes. So I would say take advantage of the tools that you have as from a technical document editing standpoint to be able to do this. Also, to the extent that something like our interview guide will be implemented for research purposes, it would probably be non-human subjects research. But if this interview guide is helpful to share with like your IRB, for example, and then the IRB might have questions, at least you have somewhere to start so that if the IRB does have questions, you can iterate and adjust from there in a manner that the IRB would prefer. You adapt around. And so I think, yes, that is given that, these are living documents, they're subject to editing based on what's locally preferred. We wanted this to be a sort of a gift in that regard, that at least you have somewhere to start. And there are tools that you can use, that are available through Google or some other form of like any a document editing, group document editing tools that you can use in order to do that. And really, again, as I mentioned, we're just giving people somewhere to start so that it's citable, it's referenceable, it's usable, workable in practice. And that way people aren't just kind of left in the dark around like, how do they even start to engage? And again, even us describing our engagement process is hopefully repeatable for others who are looking to either develop their own principles or take these principles and iterate upon them.
Great, that's super helpful. Thank you.
Yeah, you're welcome.
So what other kinds of, what suggestions have people made to you, Rachel, since this has come out? Things that people have suggested they would do differently, or ways they think to improve it. Have you gotten any of those? I mean, yeah, have you gotten any of those?
Yeah, and I really think the answer is it depends on the sort of stakeholder that you're talking to. You know, obviously our document is meant to serve those who are looking at the scope of AI machine learning development for health research purposes, but you know, there are other areas outside of health research that that might benefit from the use of these tools. And so I've had people approach me to say, you know, oh, well, you know, this is really helpful to at least get me, you know, started with how I can adapt these principles for my own scope of practice, you like for humanities research, for example. And so that's been one observation. Another observation I found is that, well, I think within the scope of health research and healthcare, like that's not a monolith. Like it's very multifaceted, where within healthcare you can develop AI machine learning tools to assist with the process of delivering care. Like in the patient doctor or patient clinician setting. And then there are tools that are meant to serve as softwares as medical devices, you know, that are AI machine learning driven or based. And then there's AI machine learning tools that assist with the administrative process of delivering care, like prior authorizations and, you know, insurance approvals. So I think as I've had conversations even across that spectrum, and I have published work, I can actually share a health affairs forefront piece that I recently published on the use of AI machine learning and private authorizations. It's important to first ask yourself, like, well, what scope of healthcare or health research am I looking at? Or even as these tools, like for example, AI machine learning or AI tools used to adjudicate around prior authorizations. Are these tools developed in research settings, like academic research settings? Should they be, or are they just only developed in the industry side? So looking at the differences between like the academic culture of developing these tools versus the industry culture of developing them, and or even publishing your results in the process of developing them, it's very different. They live on opposite spectrums, ends of you know, certain spectrums. And so I've had conversations, like I said, with, you know, people who want to implement them outside of healthcare or health research, but then also within healthcare and health research, the spectrum is broad. And some people want to listen, some people don't. Health insurance companies don't want to listen as much, but that's how they end up in the news. And you'll read more about that in this article that I just put in the chat, where some other colleagues of mine and I came up with ethical principles for the use and consideration of AI to adjudicate prior authorization claims.
So cool. Does anybody else have any questions or comments they want to make?
I have a question, Ellen, and I don't know how to raise my hand. For some reason, my Zoom platform looks really different. Can I ask a question?
Sure.
Go like this.
That's what Susanna did. So I look for that. So
Yeah, thanks. And thanks for your presentation. This is really interesting. I came in a
Yeah.
little bit late, so I may have missed something here, but I was just looking at the abstract of your paper and the people that you engaged in this process. And my question is about actual community members. And I'm thinking about, like, in Bridge to AI, some of the prospective participants are going to be underrepresented populations.
Mhm.
And I was thinking about capacity building and how do we engage people who might be involved in these studies that will be, you know, collecting data for use in ML AI model development. How do we engage with them or actually build capacity so that when we ask questions about, is this the right pathway, we think it's the right pathway for people, but is this the right pathway? Do you involve community members, and if yes, what kind of work have you done to prepare them for having these conversations?
Absolutely. So I'm glad you asked, because one thing that we were very intentional about in this principles development process is to ensure that we were, as we looked at the literature or work that's been done and published online, we wanted to pull from work that focused specifically on community, like underrepresented community engagement. And so really our principles themselves are based on work that, or at least are an adaptation of work that that I led recently through an initiative called Recode with data.org and the National Alliance Against Disparities in Patient Health, or NADPH. So I just put a link in the chat to our full report that describes the lessons learned from that engagement work with communities. We talked to all types of people to understand, or at least attempt to understand, what their local level data needs and data infrastructure needs are. We learned something else. And this was work that we actually did during the pandemic. So this was a really bright opportunity for us to really dig or sink our teeth into what was going on locally. We talked with people who represented or who worked within local public health departments, to people who were patient advocates or patient representatives within local health systems. We talked to patients themselves, underrepresented patients with multiple intersecting identities, socially and financially and economically vulnerable identities, who decided to become advocates to share their stories. We talked with them, and again, came up with a set of lessons learned from that engagement and published it in this Recode report. This Recode report actually, it accompanies some complementary work that I also did, where we learned, and I'm slowing down because I'm going to look for the paper here, but there was some other work that we did that essentially told us that by engaging individuals with lived experience and inequity, by engaging them in the data lifecycle or process, that actually leads to more equitable data management and generation outcomes. That these were findings from a survey that we did. And I'm going to look for that as well. So saying all that to say that our approach to being inclusive of individuals with lived experience and inequity or marginalized identities, we actually took what we learned from them and adapted that directly into the principles.
So I have a follow-on question then, and thank you for that. I'm thinking about the ways that we go about enrolling people into research, prospective research, where there is a consent process. There's a consent form that an IRB typically will approve if it matches and aligns with their template and has the appropriate disclaimers about what they can, what's reportable, what can be covered, what's confidential. And we assume that people have sufficient research literacy to know that they're engaging in a research study. So you have to have, it's different than becoming a patient where you have to sign a consent or you don't get treated. So we've made an assumption that there is research literacy, but and I don't know that we have that. So we build informed consent on something that probably doesn't exist, but now we have the need for technology literacy and data literacy. And when I think about enrolling people who are in populations that are underrepresented, using a traditional method of enrolling into research for a data repository that will be used for machine learning, what have you taken away in your lessons learned that could inform what informed consent could look like if we did it in a way that was meaningful and accessible to people?
For sure. Well, there are a couple of tools that come to mind to make sure that documents like informed consent documents are readable to individuals who might be less exposed or less studied around or less knowledgeable, I should say, around clinical research. And so one tool is embedded directly within Microsoft Word, where you can run a readability statistics function that gives you the Flesch-Kincaid score, essentially the reading grade level of your document. And you can adjust from there based on what that score is. So if the score is reading at, say, like 12.8 or something like that, it's telling you that the reading grade level is around that of a high school graduate. Now, if you want your document, your informed consent document, to read at a reading grade much lower than that, I know the National Library of Medicine recommends a 4th grade reading level for the general population. Again, you can adjust from there on your own, or I've even seen papers where research teams have published around their use of generative AI tools like ChatGPT to generate those documents for them at their desired reading grade level. And in fact, we did that with our principals. We played with that to say, well, how would our principals even look at a lower reading grade level? Because they do read at a very high reading level. In fact, that of a college graduate. And so that's okay for us, because we're intending to, as we publish this paper in a peer-reviewed scholarly academic journal, we want our paper to read at that reading grade level. However, if in any event we would want them to read at a lower reading grade level, we again tinkered around with ChatGPT to see what that might look like. And again, I know there are groups reporting around their use of that same tool to accomplish that same goal. But those are two practical or technical mechanisms that I know of with respect to informed consent documents that could be useful, and that actually have been endorsed by some communities implementing clinical research.
Thank you.
You're welcome. That's a really good question.
Well, I think we will give 15 minutes back. Please join me in thanking Camille, and thank Camille. I'm looking at you right straight ahead of me, Camille, but Rachel, for such a great talk, and it's always great to see you, and thank you for taking your time to talk with us today.
Well, thank you. It's great to see you all. And again, if there are any questions, or if any of you would like to connect to talk more about this or anything else related, happy to chat with you over email.
Okay, great. Well, thanks a bunch, and don't burn up for most of the country.
Same to you
Thank
all.
you.
Take care.